Well, hello everyone, and welcome back to class. This is the Self-Paced Foot Health Practitioner course, SPFHP 500 for the College of Natural Health Sciences, Bermuda. My name is Dr. Delcina Bean Burrows, and this is Module 3, the one and only lecture for Module 3. We will be looking at the anatomy and physiology of the pelvis, thigh, and knee. So this is a lecture is fairly long, so hold on to your hats and let's get started. Our Module 3 learning objectives are that at the end of today's lecture, you will be able to identify the main structures of the pelvis, thigh, and knee, including bones, joints, special structures, and deep and superficial muscles. You'll be able to label and palpate the major surface landmarks of the pelvis, thigh, and knee. You'll be able to identify and demonstrate all actions of the pelvis, thigh, and knee, the movements that are available. And you will be able to identify and demonstrate passive and resisted range of motion of the pelvis, thigh, and knee. You will also be able to draw, label, and palpate the deep and superficial muscles of the pelvis, thigh, and knee, and name their actions. Palpation should include the origin, insertion, muscle belly, and demonstration of shortening and lengthening of muscles. You'll be able to describe the function of each of the muscles of the pelvis, thigh, and knee. You'll be able to identify both the synergist and antagonist involved in each movement of the pelvis, thigh, and knee, which includes flexion and extension. You'll be able to identify movements and muscles involved in coordinated activities of the pelvis, thigh, and knee, such as running, lifting, throwing, and kicking. So we begin today's lecture by taking a look at the surface anatomy of the pelvis, thigh, and knee. Here is the anterior view, and as we can see most superiorly, right on the left-hand side of your screen, we see the iliac crest. The iliac crest is the superior edge of the wing of the coxal bone. Then you see the femoral triangle. It is formed superiorly by the inguinal ligament, laterally by the sartorius, and medially by the adductor longus. We then see the tensor fasciae lata. This is a small hip flexor which is visible in the anterior lateral thigh. We also see the rectus femoris. The rectus femoris is a primer mover for hip flexion and knee extension. We see the vastus lateralis, and it is part of the quadriceps and forms the bulk of the lateral thigh. We also see the vastus medialis, and it is part of the quadriceps and has a teardrop shape just superior and medial to the knee. The patella is commonly called the kneecap, and we see that there. And then most inferiorly, we see the patella tendon. This joins the quadriceps muscles, crosses the patella, and attaches to the tibial tuberosity. So as we get more into the study of anatomy and physiology of the lower extremity, these terms and identifications of the bony and soft landmarks in anatomy and physiology will become more familiar to you. Now let's take a look at the lateral view of the surface anatomy of the pelvis, thigh, and knee. We begin on the left-hand side, most superiorly, we see the gluteus medius, and this is the prime adductor of the hip, followed by the gluteus maximus, and it is one of the most powerful muscles in the body. We see the biceps femoris, and it is the most lateral of the hamstring muscles, which you will become familiar with. We see the iliotibial band, and it is a large, thick tendon that's associated with the tensa fasciae lata and gluteus maximus muscles. It attaches to the anterior lateral condyle of the tibia. We also see the head of the fibula, and this is an insertion point for the biceps femoris. And then over to the right, most superiorly, we see the iliac crest, we see the tensa fasciae lata, we see the greater trochanter of the femur, and it is a prominent bony landmark and insertion point for most of the gluteal muscles. Just inferior to that, we can see the rectus femoris, we see the vastus lateralis, we can still see the patella, and we can see what's referred to as the tibial tuberosity. Now let's take a look at the posterior view of the anatomy of the pelvis, the surface anatomy of the pelvis, thigh, and knee. And we're going to start over to the left, most superiorly. We see the adductor magnus. This is the largest adductor of the thigh. We see the semimembranosus. This is the most important medial part of the hamstring group of muscles. We see the semitendinosus, which lies medial to the biceps femoris and is part of the hamstring group. We see the gracilis. It is a medial adductor of the hip. And we see the pes anserine tendon. It is named for its three-pronged goosefoot shape and is formed by the insertion of the sartorius, gracilis, and the semitendinosus muscles. Over to the right-hand side, most superiorly, we can see the gluteus medius. We can still see the gluteus maximus. We can see the gluteal fold. We see the biceps femoris, and we see the popliteal fossa. It is a hollow on the posterior knee, and its borders are formed by the hamstring and gastrocnemius muscles. We are now going to look at the bones of the pelvis, thigh, and knee, beginning from the anterior view. Beginning from the left side most superiorly, we can see the iliac crest. We can also see the iliac fossa and the ilium, which is the bone, the anterior superior iliac spine, the anterior inferior iliac spine. We see the ischium. The pubic symphysis is the medial junction between the right and left sides of the pelvic girdle. It is a slightly movable cartilaginous joint. We also see, traveling down inferiorly, the tibiofemoral joint. It is a modified hinge that allows flexion, extension, and a slight degree of rotation of the knee. And we see the patellofemoral joint. The patella glides inferiorly as the knee flexes and superiorly as it extends. This maintains the leverage of the surrounding muscles during movement. And as we travel from over to the right-hand side, most superiorly, we can see the neck of the femur bone. We see what's referred to as the greater trochanter. We can also see the lesser trochanter. Then we see the shaft of the femur bone. We can see the patella. We also see what's referred to as the lateral condyle of the femur. We see the head of the fibula bone. We see the tibial tuberosity, and we see the fibula bone, and we see the tibia bone. We can also see medially the adductor tubercle, the medial condyle of the femur, and the medial tibial condyle. Now from the posterior view, beginning most superiorly, starting on the left-hand side, we can see L5. This is the lumbar vertebral bone. We can see the sacroiliac joint. It is a large stable union between the lateral sacrum and the medial ilium. We see the ilium. We see the posterior superior iliac spine. We see the sacrum. We see the ischial tuberosity, and we see the coccyx. Over on the right-hand side, we see the head of the femur, the neck of the femur, the greater trochanter, the lesser trochanter, and the gluteal tuberosity. We can see the pectineal line. We also see the linea aspera. This is a long vertical line running along the shaft of the posterior femur. It is the site of several muscle attachments. We see the shaft of the femur, and we see the intercondylar notch. We see the lateral condyle of the femur, the lateral condyle of the tibia, and the head of the fibula. And from a medial aspect, we can see the medial condyle of the femur and the medial tibial condyle. Let's now take a look at the pelvis, thigh, and knee from a lateral view. Now we're looking at the anterior gluteal line, starting most superiorly on the left-hand side. We see the posterior gluteal line and the inferior gluteal line. We see the posterior superior iliac spine. We see the posterior inferior iliac spine. We see the sacrum. We also see the greater sciatic notch. We see the ischial spine. We see the lesser sciatic notch. We see the coccyx. We also see the ischial tuberosity and the greater trochanter, as well as the lesser trochanter. Traveling over on the right-hand side, beginning most superiorly, we can see L3. This is the third lumbar vertebra. We also see L4. We see the iliac crest. We see the anterior superior iliac spine. And we also see the anterior inferior iliac spine. We see the head of the femur. We see the acetabulum. This is a deep socket formed by the fusion of the ilium, ischium, and pubis. We see the coxal joint. It is formed between the head of the femur and the acetabulum. It is a stable ball and socket joint that allows movement in all planes. We also see the pubic tubercle, the superior ramus of the pubis, the inferior ramus of the pubis, and the shaft of the femur. One thing of note is that the outline of the female pelvis, which is generally wider and more horizontally oriented than the male, is shown here most superiorly. If we go just back here, we can see that they've sort of put the red line to outline that typically in a female, their pelvis tends to be wider from a horizontal standpoint. And we know that this has to do with the fact that the female pelvis has to be properly positioned for giving birth. Now, in terms of bony landmarks that you can palpate on yourself, you want to go back and look at each of these specific areas in the diagrams that have been supplied to you, as well as what you will find in your anatomical training manuals that have been supplied to you. If you don't have them yet, you will get them. And what you're going to do is you're going to palpate for the anterior superior iliac spine, the anterior inferior iliac spine, the iliac fossa, the lumbar vertebral bodies, the rami of the pubis, the adductor tubercle, the medial femoral condyle, the lateral femoral condyle, the medial tibial condyle, the lateral tibial condyle, the fibular head, the tibial tuberosity, the posterior superior iliac spine, the sacrum, the greater trochanter of the femur, and the ischial tuberosities. We're now going to take a look at the ligaments of the pelvis and hip from an anterior view. And as we know, ligaments are what attaches bone to bone. Beginning most superiorly from the left-hand side, we can see the anterior longitudinal ligament. We can also see the anterior sacroiliac ligament. We see the sacrotuberous ligament. We also see the sacrospinous ligament, and we see the pubofemoral ligament. We can see the obturator membrane, and we see the pubic symphysis. From the left-hand side, the iliolumbar ligament is part of the complex network of ligaments that stabilize the pelvic girdle and its connection to the lumbar spine. The inguinal ligament is the inferior margin of the aponeurosis of the external oblique muscle and superior border of the femoral triangle. The iliofemoral ligament, shaped like an inverted Y, helps maintain optimal contact between the femoral head and the acetabulum, limiting medial rotation and extension of the hip. And from a posterior view, beginning most superiorly from the left-hand side, the posterior sacroiliac ligaments surround and stabilize the sacrum. They are part of a large network of thick, strong ligaments located in the pelvic region. The sacrotuberous ligament stabilizes the sacrum inferiorly and provides muscle attachment points on the posterior pelvis. The posterior sacrococcygeal ligaments anchor and stabilize the small, delicate coccyx. On the right-hand side, we can see the iliolumbar ligament. We can also see the sacrospinous ligament. We can see the iliofemoral ligament, and the ischiofemoral ligament spirals around the posterior coxal joint and assists the iliofemoral ligament in limiting medial rotation of the hip. Let's now take a look at the ligaments of the knee from an anterior view. The posterior articular surfaces of the patella sits in the femoral groove. The patellofemoral joint must glide up and down as the knee extends and flexes. The lateral meniscus is a crescent-shaped cartilage that cushions the tibiofemoral joint and increases joint continuity. The lateral collateral ligament connects the lateral femoral condyle to the head of the fibula. It prevents lateral opening of the tibiofemoral joint, the varus deformity. The patella tendon, as you can see in the diagram here, they've cut it open, connects the quadriceps muscles to the tibia. It is sometimes called the patella ligament because it connects the patella to the tibia. And medially we can see the proximal tibiofibular ligament, we see the fibula, and we see the tibula. On the right-hand side, we see the posterior cruciate ligament, which connects posteriorly to the tibia and anteriorly to the medial condyle of the femur. Stronger than the anterior cruciate ligament, it prevents the tibia from sliding posteriorly and the femur from sliding anteriorly. The anterior cruciate ligament connects anteriorly to the tibia and posteriorly to the lateral condyle of the femur. It prevents the tibia from sliding anteriorly and the femur from sliding posteriorly. The medial meniscus is a crescent-shaped cartilage that cushions the tibiofemoral joint. It has a direct connection to the medial collateral ligament. The medial collateral ligament connects the medial femoral and tibial condyles. It prevents medial opening of the knee, the valgus deformity. Let's now take a look at the ligaments of the knee from a posterior view. The knee is a modified hinge joint capable of flexion and extension. Asymmetry in size between the medial and lateral femoral condyles allows slight rotation of the tibiofemoral joint. On the left-hand side, we see the posterior meniscofemoral ligament, which joins the lateral meniscus and the medial condyle of the femur. Also on the right-hand side, we see the medial meniscus, the posterior cruciate ligament, and the medial collateral ligament. On the right-hand side, beginning most superiorly, we see the anterior cruciate ligament, the lateral collateral ligament, the lateral meniscus, the proximal tibiofibular joint capsule, and we see the fibula. Now we're going to take a look at the blood vessels and lymphatics of the pelvis, thigh, and knee, the special structures that are located within the lower extremity, beginning with the anterior view. From the left-hand side most superiorly, we see the inguinal ligament. Then we see the superficial inguinal nodes, the femoral artery and vein, the deep subinguinal node, the superficial subinguinal nodes, the superficial lymphatic vessels. The great saphenous vein of the medial thigh runs superiorly to join the femoral vein. Then over to the right-hand side, beginning most superiorly, we see the superficial inguinal nodes, and they are inferior to the inguinal ligament and drain the deep inguinal nodes. The deep inguinal nodes that lie alongside the femoral artery within the femoral triangle, the deep lymph vessels, the femoral artery and vein that run together with the femoral nerve deep to the inguinal ligament and through the femoral triangle, the femoral artery and vein and deep lymph vessels, the great saphenous vein. The popliteal nodes are embedded in the popliteal fossa of the posterior knee and the anterior tibial artery, which serves the lower leg. Let's now take a look at the nerves of the pelvis, thigh, and knee, beginning from the anterior view. Most superiorly here on the left-hand side, we see the lumbar plexus, and plexus, of course, is just another word for network or collection. We see the obturator nerve, the lateral femoral cutaneous nerve, the sacral plexus, the femoral nerve, the anterior cutaneous nerve, the inguinal ligament, the lateral branch of the anterior cutaneous nerve, the medial branch of the anterior cutaneous nerve, the rectus femoris muscle, the saphenous nerve, the common perineal nerve, the superficial perineal nerve, and the deep perineal nerve. And now the nerves from the posterior view. We see the superior cluneal nerves, beginning most superiorly on the left-hand side, the medial cluneal nerves, the inferior gluteal artery and nerve, the posterior cutaneous nerve, the medial circumflex femoral artery, the muscular branches of the sciatic nerve, the semitendinosus muscle, the popliteal artery and vein. They lie within the popliteal fossa along with the tibial nerve, the medial sural cutaneous nerve, and the small saphenous vein. On the right-hand side, beginning superiorly, we see the gluteus minimus muscle, the superior gluteal artery and nerve, the piriformis muscle, the sciatic nerve, which lies deep to the piriformis muscle, runs down the thigh before branching into the common peroneal and tibial nerves at the popliteal fossa. We see the first perforating artery, the second and third perforating artery, the vastus lateralis muscle, the fourth perforating artery, the biceps femoral muscle, long head, and of course this is a cut view, and we see the common peroneal nerve which lies lateral to the head of the fibula. And finally, we also see the lateral sural cutaneous nerve and the gastrocnemius muscle. Now we're going to take a look at the superficial muscles of the pelvis, thigh, and knee from an anterior view. And remember, the superficial muscles are the muscles that are easily palpable and they are closer to the surface of the skin. We see the iliacus here beginning on the left-hand side most superiorly. We also see the psoas, the tensa fascia lata, the sartorius, the pectineus, the adductor longus, the gracilis, the rectus femoris, the iliotibial band, the vastus lateralis, and the vastus medialis. From a lateral view, the superficial muscles of the pelvis, thigh, and knee, we can see most superiorly beginning from the left-hand side, the gluteus medius, the gluteus maximus, the vastus lateralis, the biceps femoris long head, and the biceps femoris short head. From the right-hand side, beginning superiorly, we see the sartorius, the tensa fascia lata, the rectus femoris, the vastus lateralis, and the iliotibial band. From a posterior view, the muscles of the pelvis, thigh, and knee, beginning superiorly from the left-hand side, we see the adductor magnus, the semitendinosus, the gracilis, the semimembranosus, and the sartorius. On the right hand, beginning most superiorly, we can see the gluteus medius, the gluteus maximus, the iliotibial band, the biceps femoris long head, and the biceps femoris short head. From an anterior view, we're going to now look at the deep muscles of the pelvis, thigh, and knee. Beginning most superiorly from the left-hand side, we see the psoas, the iliacus, the pectineus, the adductor longus, the gracilis, the vastus lateralis, the vastus intermedius, and the vastus medialis. Let's take a look at the deep muscles of the pelvis, thigh, and knee from a lateral view. Beginning most superiorly from the left-hand side, we see the cut gluteus medius, the gluteus minimus, the biceps femoris long head, and the short head of the biceps femoris. And then to the right, most superiorly, we can see the iliacus, the psoas, the rectus femoris, and the vastus lateralis. Now taking a look at the deep muscles of the pelvis, thigh, and knee from a posterior view, most superiorly we see the gluteus medius muscle, and it's cut away in the diagram so that you can see that it's just beneath the gluteus maximus. We also see the gluteus minimus. We see the piriformis. We see the gemellus superior, the obturator internus, the gemellus inferior, the quadriceps femoris, the semitendinosus, and the biceps femoris, the short head. Let's now review the general techniques for palpating muscles. And this is something that we will get to practice when we do during your one-day practicum, when we learn how to do nail debridements, callus debridements, and also the lower extremity evaluation. We will go over the general techniques of palpating muscles. So in order to correctly palpate a muscle, you must first locate its origin. We then locate where the muscle inserts, so locate the insertion. We locate the muscle belly. We activate the muscle belly by using resistance. We shorten the muscle, and then we lengthen the muscle. And as I said, this is something we're going to go over more in depth when it comes to your practicum. Let's talk about how the muscles attach to the pelvis, thigh, and knee. This, of course, is the anterior view, and we're going to begin most superiorly from the left-hand side. We see the iliacus, the sartorius, the rectus femoris, the gluteus minimus, the vastus lateralis, the psoas and the iliacus, the vastus medialis, the vastus intermedius, the iliotibial band, the biceps femoris, and then of course on the right, beginning most superiorly, we see the pectineus, we see the adductor longus, we see the gracilis, we see the adductor brevis, the adductor magnus, and the obturator externus. Traveling down, we also see the adductor magnus, and we see the patella tendon. From a posterior view, beginning most superiorly, of course, we see the gluteus maximus, the gemelli, we see the biceps femoris long head, the semitendinosus, the adductor magnus, the semimembranosus, the psoas and iliacus, the pectineus, the adductor longus, the vastus medialis, the adductor magnus, the semimembranosus, and the popliteus. On the right-hand side, beginning most superiorly, we see the gluteus medius, the gluteus minimus, the tensor fasciae lata, we see the sartorius, the rectus femoris, the gluteus medius, the quadratus femoris, the vastus lateralis, the gluteus maximus, the adductor magnus, the adductor brevis, the vastus intermedius, the vastus lateralis, and of course the biceps femoris short head. Let's now review the motions that are available at the hip joint. Illustration A shows flexion. Illustration B shows extension. Illustration C illustrates abduction, or some people refer to it as abduction. And illustration D shows adduction or adduction. Illustration E shows internal rotation, and illustration F shows external rotation of the hip. And of course, we're going to practice all of these during the practicum. Now, in terms of the available motions at the knee, we see flexion in illustration A, extension in illustration B, internal rotation in illustration C, and external rotation in illustration D. Let's talk about the purpose of passive and resisted range of motion, all of which these are terms that you will become very familiar with, and we will definitely practice these during the practicum. Passive range of motion. This helps to establish the health and function of inert structures such as the joint, capsules, and ligaments. So passive range of motion is when you, as the foot health practitioner, you passively range someone's joints. They don't assist, they don't resist, they just allow you to range their joints to see if there is full range of motion in the joints. Resisted range of motion helps to establish health and function of dynamic stabilizers and prime movers of a joint. So it helps identify balance and potential imbalance between muscles that share and power of the lower extremity. And here the practitioner therapist is demonstrating passive range of motion of the hip. In A, we see her passively flexing or passive flexion. Illustration B is passive extension. C is passive ab or abduction. Illustration D is passive adduction or adduction. Illustration E is passive internal rotation. And illustration F is passive external rotation. Here we see passive range of motion of the knee. In illustration A, we see passive flexion, passive extension in illustration B, passive internal rotation in illustration C, and passive external rotation in illustration D. Now we're going to see resisted range of motion of the hip joint. In illustration A, we see resisted flexion. Illustration B is resisted extension. Illustration C is resisted abduction. Illustration D is resisted adduction. Illustration E is resisted internal rotation. And illustration F is resisted external rotation. Here we see resisted range of motion at the knee joint. We see resisted flexion in illustration A, resisted extension, illustration B, resisted internal rotation, illustration C, and resisted external rotation in illustration D. Now let's take a look at the synergistic and antagonistic muscles of the hip. The synergistic muscles are the muscles that assist the primary muscles to make a movement, and the antagonists are the muscles that oppose the particular movement. So when we have the muscles that aid in flexion, for example, the extensor muscles are the ones that automatically oppose those muscles, and vice versa. Okay, so the synergistic muscles that aid in hip flexion are the psoas, the iliacus, the sartorius, the tensor fasciae lata, the rectus femoris, the pectineus, the adductor brevis, longus, and magnus, the gluteus medius, and minimus. And then for extension, the synergistic muscles are the adductor magnus, the gluteus maximus and medius, the biceps femoris, the semimembranosus, and the semitendinosus. When it comes to hip abduction, we have the sartorius, the tensor fasciae lata, the piriformis, the gluteus maximus, the gluteus medius, and the gluteus minimus. For adduction, we have the pectineus, the adductor brevis, longus, and magnus, the gracilis, the gluteus maximus, the gemellus, superior and inferior, the obturator internus and externus, and the quadratus femoris. And as I mentioned, the synergistic muscles for abduction are also the antagonist muscles for adduction, and vice versa. The synergistic muscles for adduction are also the antagonist muscles for abduction. Okay, so if you have any difficulty understanding what I just said, remember I have my office hours, so you can contact me at any time. We can go over it more. The synergistic muscles for internal rotation, we have the gluteus medius, the gluteus minimus, the semimembranosus and the semitendinosus. For external rotation, we have the psoas, the iliacus, the sartorius, the adductor brevis, the gluteus maximus and medius, the piriformis, the gemellus superior and inferior, the obturator internus and externus, the quadratus femoris, and the biceps femoris. Now let's consider the synergistic and antagonistic muscles acting on the knee. When it comes to knee flexion, we have the sartorius, the gracilis, the biceps femoris, the semimembranosus, the semitendinosus, the popliteus, and the gastrocnemius. For extension, we have the rectus femoris, the vastus lateralis, the vastus intermedius, and the vastus medialis. The synergistic and antagonist muscles for the knee, for internal rotation, we have the sartorius, the semimembranosus, the semitendinosus, and the popliteus. For external rotation of the knee, we have the gracilis and the biceps femoris. For these next few slides, I'd like for you to consider how movement is a very coordinated process between synergistic and antagonistic movements happening at a split second without us even thinking about it. So here we see illustrated there are 3 runners. Running is a series of alternating opposite motions of the hips and knees that drive the running motion. Powerful hip extensors and knee flexors bring one leg back as the other drives forward using the hip flexors and knee extensors. The body maintains its sagittal plane motion throughout the stabilizing efforts of the deep 6 external rotators as well as the adductors and smaller gluteal muscles. Now we see an individual lifting, and I'd like for you to consider how lifting is also a coordinated movement. The hip and the knee must work in concert with the trunk and upper body to lift objects from the ground. Powerful muscles like the gluteus maximus and quadricep muscles drive the motion, while stabilizers such as the gluteus medius and the adductor groove maintain a steady body position. Consider how throwing is also a coordinated movement. As with running, throwing requires different movements on each side of the body. This movement is more complex because it takes place in multiple planes. The front or lead leg plants while the body rotates around it, bringing the chest and arm forward. The quadriceps, hamstrings, and gluteals accept the body's weight, while the rotators of the hip and knee pivot the body around the foot. The back or trail leg uses the adductors to control the motion before swinging through and accepting the body's weight for the follow-through motion. And finally, we have kicking. Kicking is similar to throwing in that there is a planted lead leg and a swinging trail leg. Again, the body must pivot around the planted lead leg in order to position the body for powerful sagittal motion. In kicking, the trail leg does not contact the ground as it does with throwing. The hip flexors and knee extensors are maximally recruited to place greatest force at the foot for kicking. The gluteus maximus, hamstrings, and adductors must slow this motion once the ball has been contacted. Now let's summarize some key points in terms of today's lecture. The pelvic girdle is made up of the ilium, the ischium, the pubis, the sacrum, and the coccyx. The ilium, ischium, and pubis converge at the acetabulum, forming the socket of the ball and socket coxal joint. The sacroiliac joints and pubic symphysis allow slight movement in the pelvic girdle. The head of the femur forms the head of the ball and socket coxal joint and can move in all planes to produce flexion, extension, abduction, adduction, internal rotation, and external rotation of the hip. The knee consists of two joints, the tibiofemoral joint and the patellofemoral joint. Together, these two joints allow flexion, extension, internal rotation, and external rotation at the knee. Movement of the patella maintains the leverage of the quadriceps muscles as the knee flexes and extends. As with the shoulder, the deeper, smaller muscles in the hip, such as the deep 6 external rotators, tend to stabilize the joints. The larger, more superficial muscles, such as the gluteals, create powerful movements. The inguinal region, deep posterior hip, and posterior knee contain several vulnerable structures including lymph nodes and vessels, arteries, and nerves. Avoid these during palpation. Balance flexibility of the pelvis, hip, and thigh, enhance posture, and minimize injury such as patella tracking problems, muscle strains, and ligament sprains. Coordinated movements of the muscles of the pelvis, thigh, and knee is required during walking, running, as well as powerful movements such as lifting, throwing, and kicking. Okay, so that concludes Module 3 lecture. And for the Module 3 assignment, I'd like for you to answer the following questions. List the bones that make up the coxal joint. List the bones that make up the pelvic girdle. List the superficial muscles of the pelvis, thigh, and knee. List the deep muscles of the pelvis, thigh, and knee. List the movements available at the hip and knee joints. And describe how injury to the hip and knee joints would impact movement. And also, although it's not written here, it's a given that you are expected to, in your own time, become very versed in palpating the superficial bony and soft tissue landmarks of the lower extremity, the pelvis, hip, and knee for this particular assignment. Okay, so this is the self-paced course, which means that this assignment is due when it is due. So please go ahead and submit your assignments when you have completed the lecture and are feeling comfortable that you are understanding the information. Of course, if you would like to discuss anything in the lecture with me, you may shoot me an email or send me a text message and we can set up a time if it's outside of my regular office hours, which is on Thursdays from 4 to 6 p.m. Okay, so with that, I look forward to receiving your assignments and I will see you in the next lecture.